Evening. My name is Dr. Shakti, and we are going to be starting with our respiratory system today. So, to start off with, we'll go to basic functional organization of the respiratory system, where you understand the components and structure, and then we'll go on to understand the mechanics of breathing. This again is a foundational thing that is essential in order to understand a lot of things like regulation of respiration and compliance, surfactants, all of these questions. You need some basics of what we're going to go through. And in fact, there are a lot of questions that come from this topic. You can just take a look at it. You can see a short answer of what is an anatomical dead space, what are the muscles involved in forced expiration, name accessory muscles of inspiration. These are all related to your mechanics of respiration. Then you can see the short essays differentiate between conducting and respiratory zones of the respiratory system. What exactly is it? What are we talking about? We'll come to it today. Then explain the mechanics of inspiration, expiration. As in, what are the muscles that are involved, how it acts, how the pressure changes are involved in the pleura, in the alveolus, all of that. Okay. And then discuss the role of diaphragm in respiration. And then again, a long question. One question that is given here is describe the functional organization of the respiratory system. Usually this does not come as a long question, long essay. Only PGs get this sort of a question as a long essay. But most often questions like mechanics of respiration, maybe functions of respiration. Again, none of them are going to be a long essay. Okay, so I'm just mentioning it to you because this is basically not a long essay. So we're gonna try to understand the topic now. When we talk about this topic, we'll be talking about it under few headings. One is your introduction. In introduction, we will be dealing with your what is called a Weber-Palade model. That is regarding how your structural organization of your bronchial tree is made. Okay, so this Weber-Palade model, we try to understand that. Then another thing we have to understand in introduction is basic functions of your respiratory system. One is, of course, respiration. The other things that you have to specifically learn are the non-respiratory functions. So this specifically you'll have to learn. These are both different separate questions. Okay, then we'll go into your mechanics of respiration. So in mechanics, we'll talk about what are the muscles involved in different phases of respiration, inspiration, expiration, post-inspiration, post-expiration, all of that we'll talk about it. Then we'll talk about the pressures. The pressures we're going to be talking about will be your intrapleural pressure. Then we have alveolar pressure and your transpulmonary. There's a diagram that you need to know, a graph sort of thing that you need to learn to draw because questions come from that, whether it is MCQ or a simple draw the diagram with explanation like that. Okay, so this is again a very important thing that you need to know. Muscles, again, you have to understand the mechanics of respiration. Somehow, this question is often repeated in universities. So that's why you have to learn the non-respiratory functions. Okay, and this is especially important for your MCQs. Apart from that, questions do come, like the one we saw how difference between conductive pathway and your respiratory zones are there. Okay, so now we'll come to start with your Weber-Palade model. What exactly is this Weber-Palade model? So the thing is, your trachea, which is static. Okay, so we'll call it generation 0. That is a static. Okay, now this trachea, well, as it comes down, it'll start dividing. So once it starts dividing, it'll divide into bronchus, the main bronchus. Okay, so this will be the first level of division where you start getting your bronchus. Multiple bronchus, bronchi. Okay, now this bronchus keeps dividing further. It goes further to the second division. Like this, it'll divide again. Okay, again, after that, I'm not showing. It'll divide 3, 4th division, 5th division, 6th division, 7th division, 8th division, 9th division, 10th division. Okay, so like this, multiple divisions are there. And from the 11th division onwards, it will start becoming what is called a bronchiole. So just for you to understand, I just mentioned that. So this bronchus is going to be from your 1 to the end of 10th division. Okay, once the 11th division has started, from the 11th division onwards, what divides? Okay, so the one that divides after the 11th division, that is going to be what you call the bronchiole. What is the difference between them? We'll come to understand it. Okay, so this is bronchiole. Now, after that, bronchiole again keeps dividing further 11, 12, 13, 14, 15, 16, it divides. Okay, so till 16 it divides. So this last division of your bronchiole is a particular type of bronchiole we term as terminal bronchiole. So this is what we call a terminal bronchiole. Okay, so this again, bronchiole keeps dividing further and further. Okay, like that, it keeps dividing. Ultimately, it reaches a particular thing which is called a terminal bronchiole. So now this terminal bronchiole, so let's just consider this to be the terminal bronchiole. Okay, so this, if not exactly correct according to the diagram, but just for you to understand, I'm just telling if this is the 16th division. And then we have the terminal bronchiole. Okay. Now, after that, what you get is what you call a respiratory bronchiole. Okay. So this is going to give something called the respiratory bronchiole. Whatever is here, all of these are going to be your respiratory bronchiole. Okay, that again divides further to 17 to 19 divisions. Respiratory bronchiole divides. Okay, this respiratory bronchiole after 19 divisions from 20 to 22 becomes what we call your alveolar duct. And the last 23rd division is what we call alveoli. So this again further divides into smaller alveolar ducts, which can divide like 2 times further. More alveolar ducts like this. Okay. At the end of which we have alveoli like this. Now the thing you have to understand is this alveoli can start appearing from the point of respiratory bronchiole. Small budding of alveoli can be present from the level of respiratory bronchiole. The thing is, from this point that you're just seeing, from the point where respiratory bronchiole starts, this is what we call as the respiratory zone. And everything above that, all of these areas, which are called conductive. So remember that question. So differentiate between conductive zone and respiratory zone. So from 0 generation to the 16 generation till the terminal bronchiole is reached. That is what we call a conductive zone when alveoli are in no way present. So what happens? Gaseous exchange does not take place in any of these zones. Okay. Beyond that, your respiratory type of bronchiole starts, where a little budding of alveoli can be there. Beyond that, alveolar ducts are there, from which again you have alveoli coming out. And then finally, the last division will be your alveoli. Okay, around 300 million alveoli are present. Okay, so this is what we call the Weibull-Fallade model. Okay, and it is talking about how there are 23 divisions in the tracheobronchial tree. Tracheobronchial tree. Okay, 23 divisions of the tracheobronchial tree are present. Now, how is it changing? What is the difference between them? For that, you have to understand how in the initial layers, your trachea, the bronchus, okay, till your 11, till your bronchiole is reached. Till this point, you have these cartilage which are there around it, like this, like this, like this. This is very important because it makes sure that this remains patent and does not collapse. The airway should not collapse. So cartilages are present, especially in the initial part. From bronchiole onwards, it can collapse if the pressure changes are not according to its requirements. For example, if from outside pressure is very high, it can collapse. Okay. Another thing is the initial layers, your trachea, okay, especially has what we call a pseudo stratified. Okay, pseudo stratified kind of epithelium. So now we're talking about what is the epithelium differences. What is epithelium? Whatever cells are lining the inside. There are different types, like some will be like this, some will be like this, some will be like this. So if you look at the nucleus, it will be in different layers like this. So this is what I call pseudo-stratified. Okay, pseudo-stratified type of epithelium is there. Now, in the bronchiole and lower parts, when you look at it, it is cuboidal. So it will be cube shaped like this. Now, mind you, they're all ciliated. Okay, cuboidal. Now, from the point your respiratory, that is the respiratory zone starts. From here on, you'll start seeing that it becomes flattened and these cells become squamous in nature, like this, flattened cells like this, which are called squamous. Okay. The epithelium changes. First, cartilage. Cartilage is existent here, but not present below that. Epithelium is pseudostratified, becomes cuboidal, then becomes squamous. Then smooth muscles. Smooth muscles are present in your trachea, present in your bronchus, bronchioles also to a degree. By the time you start reaching your alveolar duct and all that, respiratory zone, there are no smooth muscles. Okay, and then we have also glands. Glands are also present, especially in the initial compartments. Later on, glands are not present. Glands are important because they secrete substances. So along with the cilia, the substances that you secrete from the glands, like the mucus and all that, help prevent foreign bodies. Okay, so with regard to the fibrocartilaginous, epithelium, smooth muscle, the glands, okay, these are various degrees by which changes occur in the tracheobronchial tree. Okay, so that is the first thing, that is the feeble palate mode. Okay, in case you wanna, briefly outline how your structure is with regard to your organization. What you have to understand is there needs to be first some kind of a pump mechanism. Some kind of a pump mechanism should be there so that whatever air is there can be exchanged with the outside. So one is your air pump. Some sort of air pump should be there. Now this should, once the air comes in, there should be some way by which there is a substance in between through which it can go inside. So some sort of a surface should be there for diffusion. Some sort of surface should be there for diffusion. Once inside, there must be some sort of a particle in a body, RBC, okay, or some dissolved components here, okay, hemoglobin, whatever it is, some pigment which should be able to carry this. Then there must be a good circulatory system which can take the blood to different cells so that respiration is there. Okay, so a circulatory system, something for carrying oxygen and carbon dioxide, the gases, whatever it is. Now, this is not all. We need some sort of local mechanism over here where regulation can happen. And we also need some sort of a central mechanism in the brain where some degree of central control can happen, which can again influence this by feedback mechanism. These are different components of your respiratory system. It's not only the lungs. This entire complex is what makes up the organization of your respiratory system. That's why I was telling this cannot come as a long question at your level because there is literally the entire respiratory system you have to explain. Okay, in case it does come, what you have to do is each chapter, under each of these headings, whatever you're talking about, try to briefly describe it. That is how you explain this question. If, for example, 10-mark question of organization, just as much as not enough. Now you'll have to talk about mechanics under this air pump. That is something we're learning today. Okay, so this is the only part we're covering today. Then later on, we'll learn about, diffusion, transport of gases. We'll learn about the regulation by local and central mechanisms, acid-base balance. So all of this now under different headings, if you mention, that gives you the answer for that question. Okay. So this is a quick thing about your feeble palate model. So just take a look at some of these questions. The conducting zone of respiratory system is primarily responsible for. So you know that it is not responsible for gas shell exchange. The first answer is not it. Will it be involved in alveolar ventilation? Because the alveolus is in the 23rd segment. So it's not really something to do with alveolar ventilation. Maintaining negative pressure, pleural cavity, we haven't even talked about that. Okay. So of the lot, filtering, humidifying, warming air. Okay, but this actually happens even before it. From the point of nose, your nostril, nasopharynx, from that point only, all of these things actually start. Okay, but of course, conductive zone also helps in all of this. So that will be the best answer of the lot. Now, which of the following best explains why the trachea remains open during respiration? This is very simple. I already explained it. This is because of the cartilaginous rings, because of which pressure changes will not result in collapse of it. But bronchioles under high pressure can collapse because they do not have this tracheal cartilaginous rings like the trachea. Now, what is dead space? So when we talk about this term dead space, what it tries to refers to is you take in a breath, that breath, how much component of it is taking part in respiration through diffusion. It's going into the blood. Now, there is going to be some degree of air which is not going into your respiration. Okay. So out of that, anatomical dead space is that part of that dead space because of some anatomic thing. What is that anatomic thing? Your whole tracheobronchial tree is divided into two components. One is the conductive zone. Main function of it is to just transmit things from outside to inside. And then once it reaches the respiratory zone, then it can go into diffusion. Okay. What about those air which came towards the end, which did not take part, before expiration happened, which did not take part in reaching till your respiratory zone, but is still there in your conductive zone. That volume of lung air that you're taking in is not taking part in your gaseous exchange. That is what we call the anatomical dead space. Okay, so if you look at the answer, anatomical dead space refers to the part of the respiratory system the air flows without participating in gaseous exchange. Okay, so this is one concept related to what we talked about, that is the conductive versus the respiratory flow. Now we'll come to the non-respiratory function. Of course, respiration is one function. Apart from that, these are the various headings I want you to look at it under. One is acid-base balance. Next is excretion. Then you have pulmonary circulation. You have temperature regulation, speech. Vibration, what it does is, filtering and prevention of foreign body. Then there are certain different cells in the body, like macrophages, mast cells, Clara cells, pulmonary alveolar macrophages. Okay, we'll talk about all of this. Before that, let me just start off with pulmonary circulation. The pulmonary circulation is a special type of circulation because the circulation which is coming, which goes to your right atrium, goes to the right ventricle. From the right ventricle, your pulmonary artery is coming. Okay, this pulmonary artery is carrying blood, which is deoxygenated, goes through the lung and becomes oxygenated, reaches the left atrium. Okay, so it's a large area where you can actually store an amount of blood in it, so that whenever your left side of the heart requires a little bit extra, you can compensate and pull a little extra. So this is actually acting as a reserve volume for left ventricular system. Up to 440 ml of extra blood can be there in this pulmonary circulation. So that is one specialty of pulmonary circulation. Second thing is, small emboli, which can be small. Okay, it can filter it from the blood. This is another peculiarity of this. So small emboli can be filtered from the blood. The thing is, large emboli and all can cause problems. Again, this is one of the reasons why cancer, which is spreading, most likely secondarily spreads to your lungs because they get stuck. These metastases, which is coming, will get stuck in the pulmonary circulation and will result in tumor growth secondary in the lung. Okay, so that is with pulmonary circulation. Next thing is temperature regulation. So as you breathe in and breathe out, warm air is going out. Okay, especially in lower animals, you see that, something called panting and all happens. Have you seen dogs when you take them for a walk in a hot day they'll be panting by the time they come back. So this is just one mechanism by which these animals, like that, they remove a lot of, heat through the body, through your respiratory system. And to a degree, we do not pant, but to a degree, temperature regulation is also a component that can be done just by increasing the rate of respiration. Okay, now the rest of the things, we'll talk about it now. That is acid-base balance, we'll talk about it. So if you look at the rate of alveolar ventilation, okay, so you see that when you increase the rate of ventilation by around 2 times, okay, can you see this? Rate of ventilation is increasing by 2 times. So when you're breathing more, your carbon dioxide is going outside from your breath. Carbon dioxide is a potential acid inside your body. It becomes H2CO3, splits to give you H+. So more carbon dioxide is released, your potential acid is being removed from the body. So increase in the alveolar ventilation of 2 times can increase the pH of 0.23. That means it becomes alkaline. Similarly, you stop breathing. You stop breathing for a long time, H2CO3, H+, and CO2, they start developing inside the blood. It becomes more acidic, blood becomes acidic. So if you decrease the ventilation by 1/4 time, pH can decrease 0.45 times. Okay, and in a similar fashion, in our body, what does it do? If there is buildup of acid in the body, similarly, we will start increasing the rate of respiration. Can you see this? From 7.4, if the pH is reducing to 7, that means it's becoming acidic. Your ventilation rate is increasing 4 times. So for any reason, if your body is becoming acidic, and from 7.4 normal pH, it goes to 7, the ventilation is increasing 4 to 5 times. Okay. Now, apart from that, one endocrine function is, angiotensin 2, something you study in cardiovascular system. So angiotensin converting enzyme is produced, which will result in conversion of angiotensin 1 to angiotensin 2. This is happening in the lungs. Apart from that, certain components like surfactants are produced in the lungs. We'll talk about it in the next class. Okay. Then certain components like prostaglandins, histamine, kallikrein, even masses in the pulmonary circulation produce bradykinin. So all of these things are biologically active substances which are some way produced, metabolized in the lungs. This is another non-respiratory function of lungs. Okay. Now, again, we already talked about, filtering, how it humidifies, and how it warms it. This is very important because outside air versus inside, our body's temperature maintained at a particular temperature, like 37 degrees. Okay, blood is circulating in that. So the air outside is not 37 degrees. It can be more, it can be less, especially if we go to a colder climate place. Now that air, the temperature difference, if we actually try to put it directly, it will end up bubbling. And that sort of bubbles can result in problems, embolism, and death. So to prevent that, you actually need this complex where you warm it, humidify it, make the pressure proper. Only then it reaches. And this is not some trivial thing. This is a very important thing that your body does. Okay. Another thing is protection. So particles which are around 30 to 50 micrometer diameter, first of all, won't enter through the nose. Okay. Around 5 to 10 micrometer diameter get impacted in the nasopharynx only and will never enter the conjunctive airway. So we have all these hairs, vibrissae hairs which are there. So they do not allow them to go beyond the nose. Then 5 to 10 diameter, nasopharynx only, they get stuck. Things which are less than that will fall on beyond it and fall in the bronchi. Now, this is where your protection happens. Here, reflex bronchoconstriction can happen, coughing can happen. And we have this mucociliary escalator mechanism where your cilia, they beat at a rate of 10 to 15 hertz. That, along with a periciliary layer and your mucus layer, helps move particles away. Okay, so this again is a very important thing. And then your protective mechanism like sneezing, cough, and all that. Okay, such stimulus in different parts will be detected by the seventh cranial nerve, and sneeze reflex can happen, where efferent is the fifth cranial nerve. So depending on which part is affected, which nerve is stimulated, a cough or sneeze can happen. Okay, that helps eject things out. Then again, we have different types of cells in the body. One important cell is pulmonary alveolar macrophages. They are important in phagocytosis. Okay, whatever particles which evade the mucociliary escalator mechanism will now be ingested by them. Okay, then all of these other, which if you study your immunology, will start making a little more sense. They process certain antigens, secrete substances which help attract more immune cells. Okay, and they can also not only by ingesting but release certain lysosomal products outside to damage certain substances. Then we have mast cells which release a histamine, slow reacting substance of anaphylaxis for inflammation and all. There are certain secretory immunoglobulins, collectins, which are important in surfactant synthesis, defensins, reactive oxygen species can be secreted, formed from your epithelial cells. Okay, so apart from this, there is one type of cell which is called Clara cell. These Clara cells are not ciliate. So they are non-ciliate and cuboidal in nature, which are important for one, defense. Okay, they secrete substances which are important in defense, or two, when there's damage to certain areas, they act as progenitor cells to help replace those. So that is Clara cells. Okay, and finally you have speech. For speech, how does your respiratory system help? You can only talk during expiration. By talking during inspiration, you cannot talk. Okay, so your larynx, vocal cord, they during expiration will contract and help in phonation. Apart from that, your lips, tongue, soft palate, all that helps in articulating that. And finally, that boom of resonance with the help of mouth, nose, and all of these areas, it can give that resonance to it. So this is how you finally have your speech. Okay. Next, we go to understand certain things about your mechanics. When you talk about your mechanics of respiration, you have to understand what is the muscles which are involved in inspiration, what are the ones which are involved in expiration. So inspiration only, you can have this normal inspiration. When you don't, have to inspire forcefully, normally you inspire. The small inspiration, the normal inspiration, we call it tidal respiration. Okay, then we have a forced inspiration. Okay, in a similar way, expiration can be a tidal expiration or it can be a forced expiration. So which are the muscles which are involved in each of this is what we are trying to understand. Okay, so now for that, you have to draw a diagram of your chest cavity. I'll just draw one lung here, another lung here. Now this lung on one side is covered outside by your rib cage. We have, different ribs which are covering it. Okay. On top, we have the clavicle. Like this, we have the clavicle. Okay, this is the shoulder. I'm just showing you from here the rib is starting. Now here we have a sternum. We have a sternum over here. Now the lungs are actually encased within a pleural cavity. This pleura, there is a visceral pleura over here, which is covering your lungs on one side. Okay, throughout its covering, visceral pleura. On the other side, we have a parietal pleura, which is attaching to the other structures which are outside. Like, for example, the rib cage, the muscles, fascia over there. Below, we have the diaphragm. Okay, so these are your visceral pleura and the parietal pleura. And in between them, we have the pleural space. Okay, so now you can see that your lungs are actually enclosed in a cavity, enclosed by all the ribs, the diaphragm, the bones, and all that, and it is a closed space. Okay, now inside this closed space, we have one muscle which is there, which is the most important of the lot. This is going to be your diaphragm. So for inspiration, this diaphragm can come down. Say, for example, from this level, it comes down like this. So usually it comes down to around 1.5 centimeter. That is your normal respiration. So every normal respiration, it comes down to a point like 1.5 centimeter. That is your tidal inspiration. So for tidal inspiration, which is a muscle which is in what? Diaphragm. What does it do? It just comes down a little. So by coming down, it creates more space inside. So we know this formula, pressure is inversely proportional to volume. Okay, so what happened? The volume here increased. In a closed space, volume increased, which will make the pressure go down. So now if the pressure here is less, and the lungs are connected to an outside structure, which is basically your tracheobronchial tree. We were talking about it. The tracheobronchial tree, which will finally bring air from outside inside, because the pressure inside was less. Because of this pressure becoming less inside, because of the increase in the volume that happened, that is how air comes in. So for inspiration, what is the tidal inspiration? What is the important muscle? Diaphragm. Now diaphragm, if you need to forcefully inspire, can be pulled down to as low as 7 centimeters. Okay. Now this is where we can have help from other muscles. One such muscle is in your rib cage, which I call intercostal muscle. There are two types of intercostal muscle: internal intercostal, external intercostal. Okay, so if you want the chest to expand, volume to increase, so that more air comes in, do you need the ribcage to be pulled outside or inside? You want it to be pulled outside. Okay, so we have this particular thing which pulls it outside, which is your external intercostal muscle. The external intercostal muscles pulls it outside. You need more air. This is where there are few other structures which are involved. So this is a person. Then there is a particular muscle which is here called the sternocleidomastoid. The sternocleidomastoid muscle. Then we have from behind, there's a muscle which is coming up like this, which is called trapezius. Majorly it's in the back, but it comes up. Then between your first rib, there is another muscle here like this, which is a scalene muscle, anterior scalene muscle. Okay, so all of these muscles, along with your for nose, no, we have the ala nasi. If you take a deep inspiration, so in this point, diaphragm acted, external intercostal acted, your trapezius, sternocleidomastoid, okay, scalene, and even your ala nasi. You see that all of these muscles are involved. So which are the muscles which are involved in forced inspiration? Diaphragm, external intercostal, trapezius, scalene, sternocleidomastoid, ala nasi. So these are the muscles which are involved in forced inspiration. And then we talked about tidal inspiration. Now, what about tidal expiration? Tidal expiration is a passive process, which means there is no muscles actively involved in. What happens? For inspiration, what did we do? We brought the diaphragm down 1.5 centimeter. Okay. Now that by recoil goes back up. That is passive expiration. So expiration, tidally, normally when we breathe, we take muscles help like diaphragm only for inspiration. Expiration normally happens. We don't have to do anything. Okay. But when we expire forcefully, that time you need some muscles to help you. So the muscle in the chest, which will push it inside, is your internal intercostal. There's a muscle here like this, which is internal intercostal. So that push from the chest is there. Now from the abdomen, something has to push. That is a lot of abdominal muscles. One main muscle, which is there right in the center, like this. There will be a muscle which is there, which is your rectus abdominis. Yes, as you can see, this your abs. Okay, we have the rectus abdominis. Then we have a structure which is sideways slanted. So it is called oblique. Okay, there are two types of sideways slanted ones. The top one is the external oblique. Bottom one that you see is the internal oblique. And apart from that, you need something straight like this, which is your transverse abdominis. What does it do? It increases the pressure inside the stomach, which will push it up, reducing the volume here, which means pressure increases. And when the pressure here increases, air goes outside. So which are the muscles which are involved in forceful expiration? That is your internal intercostal, external oblique, internal oblique, and transverse abdominis, along with rectus abdominis. So I hope you understood which are the muscles which are involved. Okay. Now look at this question. During quiet breathing, expiration occurs primarily because of there's no contraction of any muscle in quiet breathing. What they're talking about is tidal respiration. So relaxation of whatever inspiratory muscle and the recoil is what resulted in your quiet breathing. Now, a patient with damaged phrenic nerve would primarily lose the ability to. So for them, what is the problem? Exhaling forcefully is abdominal muscles. Okay. Control voluntary breathing, you can still control with other muscles. But the quiet respiration, which is only dependent on diaphragm, that will be affected. Forceful also, diaphragm is involved, but you can still use other muscles. But for normal quiet breathing, you don't generally use. So instead now you have to use all the other muscles to breathe. Okay, accessory muscles of inspiration. So that is all those extra muscles that we were talking about. Okay, so your sternocleidomastoid muscle is an accessory muscle. Scalene is an accessory muscle. Your external is an accessory. Internal is not. Internal is for expiration. Okay. Now we try to understand the next concept. I'm just gonna draw alveoli like this, a basic alveoli like this. Okay. And beyond that, we have the entire rib cage structure here. Let's just draw a rib cage structure, something like this through. What is there between them? We have the visceral flora here. Okay. And we have the parietal flora here. So between them, we have an entire space of pleura. Okay. So inside the pleura, there's some degree of pressure which is there. So normally what happens is your lungs at a particular stage called FRC. Okay. Because the natural tendency of your lung is to collapse. If there's no force, nothing is holding it together, it will collapse inside. Okay. And what is the natural tendency of your rib cage is to expand outside. Like this. Okay. So now there are two opposing forces which is acting, and inside there is a between them vacuum chamber is there. A pull from either side and a vacuum chamber inside. And because of these pull from each side and the volume inside increasing, pressure decreases, inside will be a negative pressure. Another reason is usually there are small lymphatic channels which drain away from it, thereby reducing the pressure. So this is the reason for why these two are the things that are reason for why your intrapleural pressure. Okay, your intrapleural pressure is usually negative. Usually negative. Okay, one, because lung has a tendency to recoil and go back inside. Chest wall has a tendency to go outside. Because they are both from the opposite direction and equal and opposite, it tends to increase the volume in between, thus reducing the pressure. And on top of that, the tendency for lymphatic channels to drain stuff away from it. These both contribute to a negative intrapleural pressure. Now, the negative intrapleural pressure is usually more at the base of the lung. So when you draw a lung, the intrapleural pressure is different. Usually, at the base, it is around minus 2.5, 2.5 minus 6.6 millimeter mercury. Okay, by the time it goes here, it is more, minus 10 actually here. Okay, so I usually talk about your minus 2.5, the base value we're talking about. That is because there are more muscles. When we saw here, on top we have, your trapezius, sternocleidomastoid, scalene, your intercostals, all of these structures which are there will give it a much more traction. Okay, so we're talking about the initial resting stage of minus 2.6 millimeter mercury. So we are going to draw one diagram. This diagram is there in your textbooks, which you have to learn. Okay, so your intrapleural pressure starts off from around minus minus 2.6 millimeter mercury. Now from here, you see that the intrapleural pressure, it goes down and then it comes back up. This is during inspiration. This is during expiration. What happened during inspiration? What will happen? Your muscles are acting. Your diaphragm is pulling, or for example, other intercostal muscles are acting, all accessory muscles are acting. As a result of that, what is going to happen? There is going to be more pull in this direction. More stuff are acting in this direction. So when there's now more pull, again, what is going to happen to the intrapleural pressure? Intrapleural pressure falls more. So that depends on how much. So we are going to be right now talking about your tidal. This diagram is for tidal respiration. So this can go from minus 2.6. Usually it goes to around minus 6 millimeter of mercury. Forceful inspiration, it can go up till minus 30 millimeter of mercury. Okay. So in a tidal inspiration from minus 2.6, it goes to minus 6 millimeter mercury. You expect a graph like this. Instead, what you see is a graph which is slightly different. Such difference that is happening, that hysteresis which is happening, is because of the nature of the lung. There's some bit of resistance is there, inertia is there. Okay, because of all of this airway resistance and the inertia, that is why this slight difference from what we had actually expected. Now, after this, as a result of this, what will happen? If the pressure here drops, lesser pressure here, won't that act like a suction? A negative pressure here, won't that pull this alveolus that you see over here? And won't that make it bigger here like this? Okay, so what is going to happen here? Next is intra-alveolar pressure. Now, the intra-alveolar pressure, usually outside is 760 millimeter mercury. Inside is also 760 millimeter. That we take it as a zero value. Okay, we'll take that as a zero value. From that zero value, it will go down to minus 1. It's here. And then, because of that, what will happen when the pressure here falls? Okay, so inside pressure now falls to minus 1. Outside pressure is still 760 millimeter, just fell down 1. That will result in air to now come and enter, equilibrating it, coming to normal again. Okay. Now, during recoil, what is going to happen? The push will result in the intrapleural pressure going up, which will push it, resulting in this pressure to go up to plus 1. That plus 1 pressure will be higher, resulting in air now to go outside. So thus it again equilibrates and comes back to normal. As a result of this, what happens to the volume from this point to this point? You will see that the volume inside the lung will increase. This is around 350 to 500 ml. And then that is expired. This is your tidal respiration. In your tidal respiration, these are the things that happen. So I hope now you can understand this diagram, correlate this diagram, explain how respiration is happening with the help of mechanics. And then you can talk about all of these muscles that you're talking about. Now, in these muscles, one thing you have to understand, the movement of your rib cage, your 2 to 6 ribs, that movement is like anterior, like up like this. because of the help of the sternocleidomastoid, clavicle, with the ribs, they will move in such a way that that movement is called pump handle movement. On the other hand, the 7 to 10 ribs, when they move in a different direction, outward like this. That is what we call a bucket handle movement. And the movement of your diaphragm is simply up and down like this. So diaphragm movement, we call it as a piston pump movement. These are three things I want you to remember. MCQs come from this. Okay. So now, which of the following contribute the most to creating negative intrapleural pressure during inspiration? Again, this is a mix of what we just saw and your mechanics muscles. Okay, so diaphragm along with the thoracic cavity, that is what results in the negative intrapleural pressure. Okay, so I hope you understood the basics that we were discussing about today. So again, why to choose Auricle? Because Auricle has pre-recorded sessions of the different topics that are required for your whole year. We have live sessions so that you have a one-on-one interactions with the examiner. You can ask questions. There's the express exam module, which is there. So, if you want to finish off just before the exam to revise, understand what are the important questions, you can go through the express exam module. There is also one-to-one doubt clearing sessions which are made available, and hard copy notes that are also there. So these notes have been simplified with diagrams, mnemonics and fill in the blanks, MCQs and all of that. And of course, there is also a question bank which is there, which are of different difficulty. So you can use this not only for your university exam, but for the future preparations as well. So practical sessions are also included in the pre-recorded sessions. And right now, these are the various subscription plans which are there. And you can use my code Dr.Shakthinag 20 for discount on subscriptions. So thank you for watching. You can contact the social media handles of Auricle through YouTube, Instagram, Facebook, as well as Telegram. So see you again next class.